Hi everyone, happy Friday. Welcome to the RLR edition of VMR. We're so full of abbreviations here at the CB Solvers. RLR stands for Rabih Loves Reza or Reza Loves Rabih. And clearly I love Reza more because I'm here. Though I think that you can make the equally strong argument that he loves me more because he's deciding to join VMR despite being en route and traveling. He's going to be hopping on a plane shortly, but is going to be joining us from the airport lounge unless he has a snafu. So I'll have to open my texts to see. But we're very, very excited today because we have one of our new community members, Ashutosh, who you all have likely heard about or met in the breakout rooms, who is presenting a case. So Ashutosh, do you want to reintroduce yourself to the VMR community?
Yeah, sure. I'm Ashutosh from Nepal. I did my medical school here in Nepal, and I graduated in like 2018, 2 years ago. I worked in internal medicine department for a few years under supervision. Uh, I have not yet done residency, and I think I will be applying this cycle, internal medicine, and excited to be here. I've been here for like almost a month now, and I'm super excited to present the case here.
Oh, absolutely amazing. That sounds so cool. We're really thrilled to have you here. And I have some general questions for you, but I also realize it's a special day too because we have two of our newest team members who are contributing to the experience that you have. Aisha is scribing and Marino is doing the teaching point. So Aisha, do you want to introduce yourself to this crowd and so they get to know you more and more?
Hello, my name is Aisha, and I'm currently in the Middle East. I'm studying for my step 3, and I joined CP Solvers in March, and I've absolutely loved it. I've learned so much, and it's helped me a lot for my step 3 studying. And I'll be applying for internal medicine hopefully for cardiology after for specialization. And awesome. I look forward to this case. Thank you, Ravi.
Thank you for having us. And I don't know if you guys paid attention to Aisha's master scribing yesterday. She was able to keep up with a rapidly evolving case from hypotension to shock to whatnot. So Ashutosh, I have a sneaky feeling that today will be a little bit of a gentler case unless we're getting hypotensive again, but I guess we'll see. Aisha's ready for it all anyway. Marino, do you want to say a quick hi?
Hello guys, I'm Marino. I'm also like Ayesh, studying for step 3, but I'm from the Dominican Republic, so I'm here in the Caribbean. It's like really hot in here, but I've been joining CP Solvers frequently for the last month, and I've really enjoyed it. Actually, it woke up like the spark that I have for the love in medicine. So now I feel better than ever practicing medicine.
Amazing. Well, from the Philippines to the from Nepal, actually, I was thinking of Bettina, who just texted me, but from the Middle East to the Caribbean to Nepal to the airport lounge in Los Angeles. Hi, Prof. Rez.
Good morning. If my internet is a bit unstable, I will jump on my phone. I'm actually at a restaurant. I didn't access the lounge.
Oh no. Does this work for you though?
Definitely. I've ordered the avocado toast in your honor, Robbie. And I look forward to eating that and chewing up this case that you have prepared.
Amazing. Well, speaking of Ashutosh, I'm curious if you can tell us before we jump into the case, what is the most Nepalese thing about you?
Oh, I love momos.
Oh, yeah?
That's like a kind of dumpling.
Yeah.
I'm not sure like where it originated from or anything like that. I'm not very sure about that, but it's like a very popular snacks here in Nepal, and I love that.
Yeah, the cadence of your voice reminds me of one of my favorite restaurants owned by Nepalese immigrants to California. It's called Taste of the Himalayas. This is a free advertisement for them. It's called Taste of the Himalayas, and it's in Marin, California, and it is just unbelievable. Their lamb momos are out of this world. I would have them for breakfast, lunch, and dinner, and midnight snack, and anything. But I'm sure your case will be as juicy as a nice warm lamb momo. So take it away, my friend.
Sure. So I would start with the chief concern. We have a patient, a young female in her late 20s, presenting with dry cough and shortness of breath for 1 week. Do you want me to stop here?
I actually, if I may do a quick teaching point, how do you pronounce your name?
It's Ashutosh. You can call me Ash.
Ashutosh. No, Ashutosh. I love it. Ashutosh. I just want to make this like a 15-second teaching point. Many times in clinical reasoning, we have to decide what chief concern to tackle and use as our center of gravity. And so I have this question for the audience. Are you going to tackle shortness of breath or the cough? I'm going to just put that out there in the universe, but please continue presenting, and then we can comment on which one we would tackle and explain why you would tackle which one.
Shall I continue? Okay. So dry cough and shortness of breath symptoms were associated with like a 6-month history of intermittent low-grade fever and episodes of high-grade fever spikes in between of that. Fever, when we talk about fever, the temperature was around like 99.8 Fahrenheit, with a spike of up to 102 Fahrenheit noted every 1 or 2 days. There was no history of night sweats. It usually lasted for a few days to a week and has become more frequent prior to the hospital visit.
Wow, what an intriguing history, Ashutosh. So I'll summarize. It sounds like we have a young woman who is now seeking care because of some respiratory symptoms, cough and shortness of breath. But the background of that, more acute 1 week duration, is this very interesting pattern of inflammation with high-grade fevers that seem to be episodic, but those episodes are getting more frequent. Is that a fair summary of the data that we have so far, Ashutosh?
Yeah, that's exactly what's going on.
Really, really interesting. Well, I'm glad I got the problem representation right. I don't know if I can generate a better thought, but I think if I just analyze the context of the fevers and then pass it on to Prof. Rez, I think there's two things to discuss here. One of which most of the CP Solvers VMR community members are probably familiar with, which is to take fever and turn it into inflammation, and then as soon as you hear inflammation, turn it into acute or subacute. And subacute inflammation has a much broader DDX than acute inflammation. So here we have subacute inflammation, prioritizing unusual infections, but also opening the door for autoimmune diseases, cancers, and other rare things. But that we've practiced many times. I think what's really interesting is to ask yourself, why, what kinds of diseases cause both fever to present and then to remit and then to recur again? In other words, if you're drawing this on a graph and you're graphing it, you're doing this, right? But each episode is getting worse. So the key part to focus in on for its diagnostic specificity is to answer the question, why does it go down? Why is there at least partial spontaneous improvement? That is hard to imagine that is a characteristic feature of many infections, though the word relapsing fever does evoke some kinds of infections, with malaria being the most famous example, though it is a feature of other things. So I will say that the most helpful aspect to study inflammation is where it is localizing, and that the 1 week of symptoms gives us something to speculate about. But another unique feature of this inflammatory syndrome is its ability to spontaneously improve. So we'll have to study that in more detail. I haven't encountered this situation very frequently enough to know a very astute way of navigating it. But because I've encountered it so frequently, I'm realizing that it is a relatively unique aspect of this case. Other thoughts, Prof. Rez?
I absolutely love that, Robbie. What I love most about what you taught was recognizing when something isn't a common presentation and whether it's a clue to like prioritize VDX. And you may not know that now, but I promise after this case, when you study, you will have a prioritized VDX. For me, the shortness in breath and cough, going back to my initial question, cough is quite non-specific. It has a very broad DBX. And so stuff like cough, fatigue, nausea, dizziness, if you have other chief concerns that are more juicy, focus on that. So here, the shortness of breath. And when you tackle shortness of breath, probably 95% of causes is either due to the heart or the lungs. It's really nice to have this base rate approach to any kind of problem. And what the cough does for me, it tells me that for sure there's something going on in the heart or the lungs, as opposed to other causes of shortness of breath, like deconditioning or anemia or metabolic acidosis. So now I'm using the other symptoms that help make progress on the initial chief concern. And if you ask the question, heart or lung, I would say lung over heart for cough, but heart can certainly cause backup the pathology in the lung to cause cough. So then we take one more symptom, and that's the inflammation of the patient to even make more progress. So now we're not just dealing with a cardio or pulmonary process, we're dealing with an inflammatory cardiopulmonary process. And when we say inflammatory cardiopulmonary process, if you look at the heart, just break the heart down into the myocardium, the endocardium, the pericardium, and a rhythm disturbance. A pure rhythm disturbance shouldn't cause inflammation, though there can be inflammatory processes like a myocarditis that leads to a rhythm disturbance. So to just put some firm diagnoses on what we're discussing here, myocarditis, endocarditis, pericarditis. As you see, I keep saying itis to explain the inflammatory cardiac processes. Within the lung, it's really easy to understand how lung can lead to inflammation in the form of pneumonia, pleuritis, and such cavitary lung lesion, lung abscess, etc. But can we use the tempo and the relapsing nature of this fever to even make further progress? Because, Robbie, like if someone had myocarditis, I just don't, now I want to dance with you, my brother. Like myocarditis, it caused like 6 months, low grade. Like it just seems unusual time course for that specific diagnosis. Endocarditis, you definitely can have subacute endocarditis that maybe was causing intermittent episodes of inflammation. And what I'm thinking now is the process not be primarily in the lung or the heart, be somewhere else, but now you're seeing end organ damage of wherever this process is hiding. I want to give the mic back to you to just see if you can make any more progress. So we started with cough, shortness of breath, we focused on shortness of breath, we used the cough to say cardiopulmonary, then we use the inflammation to say inflammatory cardiopulmonary. Now I'm wondering the subacute relapsing feature, if that can even make us have more progress into where anatomically we're dealing with.
Oh, Professor, I think that's such a fantastic, fantastic reflection. And I was sitting there trying to think, what part of this case is making me uncertain about whether it's a heart or lung? Because I see that you're also going back and forth between man, there's no good strong fit, in large part because of the pattern. And I think honestly, where I'm at is because this pattern is so unusual, I have to step back and say, is it even worth investing a lot of energy in believing that this pattern is accurate? Because the patient may be experiencing this at the phenotypic level, but maybe there's something sinister in terms of occult symptoms that she is not quite recognizing or aren't of magnitude enough and are drowned out by the height of the fever. So that's possible. Is this really worth investing energy in? But it's always a fun academic exercise to at least try and then see what you learn. And for me, I'm just so struck by how she can have such high fevers and have no overt symptoms at that time of cardiac or pulmonary disease, only for it to emerge after 6 months. So how does my mind solve that? It solves that by wondering if there's a problem between the heart and the lung, not in the heart and lung. And what do I mean by that? In the mediastinum. So is she having intermittent mediastinal lymphadenopathy? Is she having intermittent aortitis or pulmonary vasculitis or some sort of inflammatory syndrome as a bridge between the two? Because I find that a little bit easier for that to eventually start to irritate the bronchi to cause a cough and shortness of breath, to eventually, it's hiding there and 6 months later it shows up. But Honest answer, there are too few N's in my experience of this syndrome to be confident. So the reflex is to be like, well, there's so few N's. So is this really an accurate representation of what's happening? Or is this a really good opportunity to learn something new to advance our knowledge? One of those two things is true. I promise.
I should touch. I promise we're gonna give you the mic, sir. I just wanted to say something, Rabia. I love this sort of like, is it a bridge between the two? In fact, recently that type of thinking led to a patient diagnosis of cauda equina, where we weren't sure, is it in the spinal cord or the peripheral nerve? And then some genius like yourself said, well, could it be a bridge between the two? And don't forget the cauda equina. So thank you for that.
Ashutosh, you have us very, very intrigued. Please tell us more.
Sure, great discussion. So moving forward, the softness of breath was like gradually worsening over the course of past 6 months without any obvious precipitating factors. Regarding negative histories, there was like no history of recent travel, recent change in weight, hoarseness, orthopnea, syncope, hemoptysis, yellowish discoloration of eyes, abdominal pain, or decreased urine output. She also did not have like wheezing, sputum production, or paroxysmal nocturnal dyspnea. She had pleuritic chest pain every now and then. Am I going too fast, or it's okay?
Oh no, Aisha has aptly summarized your long review of systems, which was very helpful, into no associated symptoms, which is masterful. Really
Sure.
nice.
Yeah. So there was like no history of allergies or retrosternal burning chest pain, no history of pulmonary tuberculosis, at least diagnosed, like previously diagnosed, valvular heart disease, cystic fibrosis, chest wall deformity, or neuromuscular disorder. Patient was not taking any medications for any chronic condition, though she had taken multiple antibiotics prior to our hospital visit. Regarding social and family history, it was mostly unremarkable, and there was no history of substance abuse. She was farmer by occupation, and involving both like agriculture and cattle. She lived in a hilly area of Nepal. There was no significant bird exposure, and she had no pets.
Oy, oy. Ashutosh, you're giving us a fantastic history here, aptly captured by our fantastic scribe, that really fits onto a template for solving inflammation that's really important. And I'll just share that broader template, and then I'll tap into Prof. Rez's mind as to how he's solving that. So the template really is answering the 4 W's. You need all 4 W's to be able to solve inflammation. What are those 4 W's? Who is the patient is a description of what their host factors are in regards to inflammation. So pertinent findings for who is the patient immunosuppressed? Does the patient have a history of autoimmune disease? Does the patient have a history of cancer? So who are risk factors for the inflammatory diseases? Immunosuppression, history of malignancy, history of autoimmunity. Who? What is the hardest part? What is an accurate description of the clinical syndrome that continues to be updated with more and more data? So far, the what is subacute systemic inflammation with features of thoracic localization. Thoracic localization is the pleuritic pain, the progressive shortness of breath, the dry cough. Notice I said thoracic to capture the lungs, the heart, and everything in between, including the esophagus. Who, what, when? When is the time course? And here it's subacute. Where is the final W? Who, what, when, and where? Where is key because it is a reminder that especially infections are largely a function, subacute infections are largely acquired from either other people or from the world itself, the farm, pets, agriculture. And understanding what infections are at play is really an understanding of epidemiology. But where isn't just a function of infection. There are tumors that are geographically restricted, or not restricted, geographically mapped out. So gastric cancers are much more common in some parts of the world than others. So what are the who, what, when, where of this patient? Who is an otherwise healthy person? The what I mentioned already, the when is subacute, the where is as outlined in the health-related behaviors as a farmer in Nepal with no bird exposure, no pets. Prof. Rez, what are you doing with all this data? Where is it taking you?
First of all, I'm just basking in the brilliance of the 4W, which I love, and I think it really grounds us. I think I'll just make a few comments here. One is the pleuritic chest pain. Pleuritic chest pain is even more specific than shortness of breath. So if you had cough, shortness of breath, and pleuritic chest pain, focus on the pleuritic chest pain. And that's where you have to think about the 5 Ps. Did you know how I did that, Robbie? I did one more than you. Not 4 Ps, but 5 Ps. I actually don't know if there's 5 Ps, but PE, pericarditis, pleuritis, pneumonitis, and pneumonia. And actually the location of where that pleuritis is, if they say it's left-sided or right-sided, can allow you to really feel confident that there's some kind of pathology in that location. So right now, without the findings to suggest heart failure, I'm really prioritizing a plural parenchymal process. And if Ashutosh told me it was the left side or right side, I would, focus that on my exam, and the imaging is going to be clutch. As far as the social history, the where in terms of the 4W, the agriculture, the farmer is exposed to soil. And in soil, there's all sorts of infections like spores of fungi that can be inhaled. And then the route to the disseminator is through the lungs, so you can make the pulmonary process. But also in soil, you can get lesions on the skin, like sclerothrips, that can cause infection of the skin. And then finally, being a foreign animal, being a farmer, working with farm animals, Robbie has one of the best NEJM cases I've read to date. It's in NEJM. If someone can find that, it's in NEJM. And I don't remember the specific title, but the point that Robbie made in that case is you don't need to have like known exposure to Coxiella burnetii to potentially have true fever. Meaning that these spores can just hang out in the environment. If you drive by a farm, you can get that infection. Robbie, what was the name of that NEJM CPS? I think that one was just so good that
I'm just basking in the chat right now because our VMR crowd is keeping you honest. You only said 4 Ps, so you're back to the 4 Ws.
I can never do, even if I want to be better, I can never do that.
Thank you all.
Instinctively, it's not possible.
I think there are 5 Ps, but I can't remember the 5th one. Anyway, it's histology rings true.
Histology rings true. This is the worst CPS case I've ever read in my life. Don't read it. Anyways, Mike, back to you, Ashutosh. I don't know where I'm going with all this, but there's exposures. We're worried about atypical infections. The exam, imaging is going to be key, and then we go from there, my friend.
Okay, I have to balance the books for the folks listening on YouTube. Deborah pointed out the final PE, which is P, which is pulmonary embolism, or PE. So you did say 5. Ultimately, Reza greater than Rabih by just 1 letter, though.
Deborah always comes to my rescue. I wish I could give her half this avocado toast.
All right, Ashutosh, tell us more, please.
Yeah, sure. Love to discuss it about 4 Ws and 5 Ps. Regarding physical exams, we have blood pressure of 110/70. Heart rate was 68. EKG showed normal sinus rhythm. And respiratory rate was 24. SpO2 was 94% at room air, and temperature was 99.8. General exam showed pallor and non-scarring alopecia. There was no rash. Sinuses and clubbing were absent. Patient appeared euvolemic, and JVP was normal. There was no cardiac exam showed like no murmur, no gallop, or no any added sound, perfectly normal. Lungs exam, there was like decreased air entry bilaterally at the bases, infrascapular and infraaxillary regions. Tactile fremitus was decreased, and percussion showed dullness in the same area. Trachea was midline. and there was no organomegaly noted. There is one musculoskeletal finding that I think I'm not sure whether I should present it right now or should I stop for a little bit of discussion here.
Whatever you think, my friend. Trust your instinct. What are you inclined to do?
I think we should probably stop.
Okay. All right.
Right. Maybe what I'll do is I'll start talking about alopecia because I don't have a great approach, and then pass the mic to Robbie to talk about everything else and alopecia. But it's something that's just odd because this is a young woman who's presenting with, and you said non-scarring alopecia, I believe.
Yeah, yeah,
Non-scarring alopecia. Got it. And in general, like my very limited GDX for alopecia, one is androgen-induced alopecia, and this is most common in men who are aging, but can also affect women as well. This is not androgen-induced alopecia. The second reason for alopecia in a young person can be stress-induced that triggers autoimmune alopecia, where you get like scattered areas of non-scarring alopecia. The third etiology for alopecia I can think of is lupus can affect the hair, but if I'm not mistaken, it's more of a scarring alopecia, but I'm not completely sure. So Robbie, I really don't have a great approach, but I know this is so unusual that I have to pay attention to it. I was hoping I don't know if you have a diagram or a schema, I'm sure you do. If you can share, like, what is the approach to alopecia and talk about the rest of the exam.
You know, I think of the 7 Ps as the cause. I'm just kidding. I enjoyed that too much. Yes. So we had a case of, actually see a fair amount of alopecia in my real life practice. So got some exposure with that. And I think that what you just did, Prof. Rez, is the best, more practical approach, is to try to divide alopecia into categories because it's too broad a category. So scarring versus non-scarring is a great category. And then patterned or non-patterned alopecia. So is it occurring in a specific geographic distribution, like an androgenic pattern or a female balding pattern? Those will take you very, very far. I was listening to you closely, so I didn't pull it up on my Evernote, but I'm happy to. Do you want to, maybe you can discuss everything else while I try to find a schema in Evernote? Yeah.
Absolutely. So the rest of the data, this patient for sure is inflamed. You might say, well, wait a minute, that temperature doesn't categorize them as fever, but we have enough data to tell us that they're inflamed based on the HBI. The oxygen saturation of 94% is not normal. And that sort of matches with the pulmonary exam where we have decreased entry of air. So decreased breath sounds in the bases probably suggests that there's pleural effusion. You couldn't get atelectasis, but with the pleuritic chest pain, I'm worried about a pleural parenchymal process that goes along with the decreased tactile fremitus. So right now, I'm worried that there's going to be something in the pleural phase. There's going to be something in the parenchyma of the lung. And the pallor is really fascinating. So this reminds us that there can be multiple reasons of shortness of breath, although anemia doesn't explain the cause, but anemia can be a contributing factor to the shortness of breath. So what is my mind doing? It's saying we have inflammation. It's saying I have pleural parenchymal process. And it's saying I have something that's causing a high degree of anemia. Usually anemia of chronic disease doesn't cause significant pallor. So this would prompt me to send labs for hemolysis to see if they have to add hemolytic anemia into our growing problem list with the hope of identifying a unifying DX.
Amazing, Prof. Rez. Before sharing the schema, I'm gonna tell you all about something since we have a lot of new folks on VMR here and maybe watching on YouTube. So these schemas that you've seen us share before, a vast majority of them are already on RLR CP solvers. And that's, if they aren't, that's where their destination is. So Reza and I spend an hour with you all once a week, but we pour in much more effort, about 15 to 20 hours to create content for RLR CP solvers, and see the website here.
This guy has me reading about rectus sheath hematoma for 5 hours.
Yeah, we really pour our heart and souls into this work. It is behind a paywall. the good news for you all is if you are a student or if you are an international medical graduate, there's a 50% discount. So really hope you'll consider checking it out. But for now, I will share with you this. Oh, by the way, you should know that the funding that we get from RLR CP solvers is really what allows us to do what we're doing right now. Because nothing's for free, lovely people, unfortunately. Alopecia categories: focal versus diffuse, scarring versus non-scarring are very helpful. And then within diffuse alopecia, there's things that are very common, like pattern alopecia, male pattern balding or female pattern balding, and then telogen effluvium. Telogen effluvium is the description of alopecia under stressful conditions, usually pregnancy, but other things. So you can see the landscape is very broad. It's also going to be very helpful to try to get a sense of what the pattern is. Okay. So I'll leave this up here for you, and you'll find it either currently or in the future up on RLR CP solvers. But I think, Prof. Rez, if I were to try to integrate reflexively without studying the schema in more detail, what the alopecia signifies in this case, I think alopecia in the context of a cardiopulmonary disease is a hard sell for the infectious causes of alopecia. Syphilis is a nice infectious cause for alopecia, but doesn't usually have a prominent cardiopulmonary signature. Leprosy is probably the most common infection causing alopecia, but again, for it to disseminate into the heart and lungs is very rare, though it's doable. So there is an entity called alopecia, paraneoplastic alopecia, which happens as a result of a cancer, but that's much less common than the autoimmune categories of alopecia, of which essentially there are two: lupus and dermatomyositis. And the overlap between lupus and the lungs is much less so than dermatomyositis in the lungs. And yes, I may be primed and biased because of what Ashutosh already said. He said he has an MSK finding, which made me think of the muscle, namely dermatomyositis. But I think autoimmune alopecia in the context of an inflammatory syndrome probably makes you wonder, wait, what kinds of infections? But the infections that do it usually stay at the surface: syphilis, usually don't enter the heart and lungs, syphilis and leprosy. The cancers that do it are very possible, but they're much less likely than autoimmune disease. So for me, I'm wondering, are there any cutaneous findings or MSK findings of either lupus or dermatomyositis? Alrighty, Ashutosh, tell us more, please.
Yeah, sure. I think I'll have to share my screen. So I do have, I can share my screen here, right?
Yes, you can. You should be good to go.
Is it visible?
Yes, yeah. Wow.
So this is the MSK finding I was talking about. So the patient actually had these hyperextension deformities in proximal joints and hyperflexion deformities in distal joints. So I do have a few other imaging. So shall I give the imaging right now or the other labs first?
I could just share my reflex thoughts on this image finding and pass the mic to you, Prof. Rez. It's evoking for me what's called Jacob's arthropathy, the idea of hyperextension and hyperflexion across the DIP and PIP joints. But unfortunately for me at this time, it's nothing than just a reflex association that is all the way back to step 1 and step 2 studying. I haven't thought about this condition since then. So I'll just tell you that what I'm about to say is 10 years old. This is an association that I have with autoimmune diseases, and it's a non-deforming arthropathy. So the joints are actually okay. I forget what the pathophysiology is, but I'm excited to read more about it. And the reflex associations I have are with autoimmune diseases, and I think lupus is the most likely. This is in stark contrast to the swan neck deformities associated with rheumatoid arthritis, but which is distinguished by the lack of joint swelling and the lack of ulnar deviation, which patients with RA have. But my confidence on these things is about 51%, just 1% above the mark where I'm comfortable sharing it with you. Prof. Rez, where are you at?
I am right there with you. And I think, yeah, it's something that I'm gonna have to read more about. I'm interested in more data to see if we can make progress.
Sure. I'd like to run through our labs quickly, and then I'll give you a few more imaging. We did COVID-19 PCR, which was negative. CBC showed microcytic anemia with hemoglobin of 9 milligrams per deciliter with NCV of 74. The reticulocyte count, I do not remember exactly, but it was like a normal reticulocyte response. The WBCs were 4,500, with 40% being neutrophil, and platelets were 68,000. Inflammatory markers like ESR and CRP were both elevated. Blood and urine cultures were negative. Serum procalcitonin was within normal limits. AST, ALT, urea, and creatinine were all normal. Bilirubin was 1.7, with indirect bilirubin was 1.3. So I have 2 images. I have to share this screen again. So this is the X-ray of the patient, the X-ray of the hands. What we appreciated in this X-ray was there was some osteopenia in the joints, and yeah, that's it. The other. So this was the other image. This is the chest X-ray. There was some pleural fluid noted in the noted bilaterally. The pleural fluid analysis was done, and we can discuss the reports of the pleural fluid analysis. Do you want me to stop here, or shall I continue?
Ashutosh, I think this is an excellent place to stop and reflect and to use the power of the breakout room. So we've opened them for you. We'll go in there for 5 minutes or so folks can share their ideas and connect and come up with your thoughts together. So we'll take a pause and really engaging conversation and let you all share your thoughts in the breakout rooms. I'll say for those of you on YouTube, please hang out for a few minutes, collect your thoughts, write them down, and we'll share them all in a few minutes.
Hey, Robbie, can you hear me?
Yes, sir.
Sorry, man. The internet is a little bit unstable.
Oh, really?
What did the imaging of the chest show?
Imaging showed bilateral effusions.
Bilateral effusions. Okay.
Yeah. So, yeah. Did you catch? Is there anything else that you didn't catch?
No, that was it. I think the way I would summarize this case so far is subacute inflammation, non-scarring alopecia, Yakut's arthropathy, bicytopenia with the thrombocytopenia, the anemia, maybe mild hemolysis with that indirect hyperbilirubinemia, and then bilateral pleural, and I bet you there is parenchymal pathology if the CAT scan was done in a young patient, in a young 20-year-old patient. And my reflex thought is the following: are we dealing with some kind of overlapping autoimmune disease? specifically the mixed connective tissue disease, because there's flavors of lupus here for sure. And even though the patient isn't leukopenic, I think it's still fair game for lupus to cause many of these manifestations. And honestly, I'm just trying to wonder, like, is there anything I can't explain with lupus? Because lupus is really good for floral disease, pruritus. Lupus is very good for, autoimmune related joint issues and hair issues. And lupus is really good for hemolysis and polycythopenia. So I don't even know if I have to invoke an overlapping syndrome. What do you think?
Yeah, no, I'm honestly in the same situation. Yeah. I think that there's so many there's the going back to the inflammation, I think there's so many features of this case are very, very suggestive of lupus, and I'm right there with you. I'm just wondering if we should share our thoughts now or just wait for the crowd to come back to share them, because I think last time we just had to like update them.
Well, I see. So was the recommendation to just hold off on us speaking and just?
Yeah, to kind of
Oh,
let
I'm sorry, but I didn't catch it.
Oh, no worries at all, man. Yeah, to like let people on YouTube and let people kind of just like collect their thoughts. But
Dude, wow, my teeth are looking so straight now when I smile.
oh yeah. How was the avocado toast?
Oh my gosh, maybe one of the best I ever had.
What? Is it just plain
It was-
avocado or something else on it?
It was avocado. There was like lettuce with like a dressing on it. Not like lettuce. I don't know the exact terminology for it, but little tomatoes, some almonds, and some balsamic and vinaigrette dressing just like overlying it. And then the avocado toast was like buttered on that very nice brioche-like sliced bread. So it gave a bit of a crunch with like sweet.
Oh no. Oh, your internet went out, Professor. You
I
sounded
know.
you sounded like a food critic. You're like a little bit of this and a little bit of that, a little bit of this. It was pretty impressive. Are you still watching Graham Ramsay or Gordon Ramsay? What is his name? Graham Ramsay or Gordon Ramsay?
Man, we've moved on to other stuff now, but yeah, when I have to get back to watching him again.
What's his name though? Is it Gordon or Graham? I gotta look this up. Oh no, Prof. Rez, I'm gonna have to use Google. Gordon Ramsay. All right, folks. Folks are slowly trickling back in. Slowly. Very rich discussions, I'm sure, given the slow pace of the return back. Prof. Rez, you made it. All right, folks are slowly coming back. I'll let you know when everybody's back. And then we can hear some magic. Yeah, it looks, Prof. Rez, the video looks so much more smooth. Like I can tell your connection looks better just from the smoothness of your video. Awesome.
From the smoothness of my bald head.
Yes. All right. I think everybody's back. I hope you guys had a good time and a good conversation in the breakout rooms. Prof. Rez and I were talking about avocado toast and other things. We promised we would save our medicine conversation for now for everybody to reflect on. So, Prof. Rez, take it away, my friend.
Yes. First of all, apologies to those listening to this on YouTube. I initiated some of our thinking earlier, but this is how we're framing this case. Young woman with subacute inflammation localizing to the pleural parenchymal space. We pretty much think that there is probably parenchymal involvement if a CAT scan was done. Also, having bicytopenia, anemia, thrombocytopenia, mild hemolytic anemia because of the elevation and the indirect hyperbilirubinemia, alopecia that's non-scarring, plus Jacquet's arthropathy. Like this is our problem list, and we're trying to determine if we can, thank you, we're trying to determine if we can arrive at a unifying diagnosis. So right away with young people, recently I heard this framework from Rebecca Berger, which I think is really, really amazing. It's the 3 Bs: bad luck, bad genetics, bad behavior. And in this patient, we're really leaning towards an autoimmune disease. And we brought up the possibility of lupus. And we asked ourselves, is there anything that we can't explain with lupus? Because lupus loves the pleural space. Lupus can cause an autoimmune hemolytic anemia. Lupus, I bet you, can also cause a non-scarring alopecia. So there wasn't really anything that we couldn't explain with the possibility of lupus to suggest an overlapping rheumatologic disease. It's really important. I didn't appreciate this earlier in my career, that these rheum diseases, they really, although we did have distinctive categories and diagnoses, there's a lot of overlap between them. So I think where Rabih and I are is the following, is getting an ANA, double-stranded DNA, anti-SMIP antibody complement levels, and most importantly, getting a urinalysis to see, is there any evidence of glomerular nephritis? Even if the creatinine is normal, you can certainly have a GN that comes with just proteinuria and hematuria. So bottom line is, the question is, does this patient need immunosuppressive therapy now? And Rabih, I would love for you to comment on this next stage, which is, whenever I'm thinking I want to give immunosuppressive therapy, have I ruled out all possible infections? And is there any infection that I need to screen for before initiating such therapy?
Absolutely amazing, Prof. Rez. I'll just share 3 observations to answer that question. The first is, remember when we talked about we have to explain the downward improvement, spontaneous improvement of the fever? Here's an explanation: autoimmune diseases. And honestly, I'll just be honest with you. I had that instinct for the downward improvement. How can people with inflammation get better? And I think I'll have to study that more. Like, how specific is it for autoimmune disease? But it's really hard for me to imagine a long list of infections or a long list of cancers that can improve the fever and then come back. But it is a very almost characteristic feature of autoimmunity. And then the case for autoimmunity, I think, is augmented by the leukopenia here. Because think of the number of infections that can cause a leukopenia. There's not that many. It's tick-borne infections, HIV, really, it's really 2 of them: tick-borne infections and HIV. So I think an HIV test in this person is going to be really, really important. But it's hard, really. One almost reliable feature of advanced HIV is the presence of prominent GI symptoms, HIV enteropathy. So the lack of GI symptoms here has my pretest probability of HIV very low. So I think those are the really 2 those are the key infections. Of course, in this epidemiological population, you want to make sure there isn't TB or a granulomatous infection And TB can cause this pancytopenia, but it's usually in the face of advanced TB, which this patient does not seem to have given the relatively clear lung findings they have. I think the most powerful, I think the most powerful observation here is exactly what you said, Prof. Rez, about there's nothing that's incompatible with lupus. And I'll just, the third observation I wanted to share, actually maybe best Oh, sorry,
Okay, you're back, Robbie.
Yeah, I'm back. Prof. Rez, I just have to, I have to follow in your footsteps in all ways, including having my video frozen. I was just going to share, I wanted to share a quick observation about the X-ray, if you wouldn't mind pulling it up, Ashutosh, because it actually, for me, made me think of something really rare, but associated with lupus, like Prof. Rez already said. If you wouldn't mind pulling up that X-ray, I think it's an interesting
Sure.
reflection to have.
Sure.
Take your time. No
The X-ray of the hand, right?
Oh, no, sorry. X-ray of the chest. I'm sorry. For
Okay.
me, I think X-ray, all I think is the chest, because I never read these these hand X-rays. All right.
Is it visible?
This is perfect. Thank you so much. Team, look at these lungs. They're so small. We're talking about a 20-year-old woman whose lungs are this small. And only because we were building the pretest probability by listening to Prof. Rez for the pretest probability of lupus, can anyone think of why the lungs would be so shrunken? Why you're saying ILD? The most common manifestations of ILD on X-ray are, yes, there you go, Nalayan. So, yeah, I'm wondering if this patient has the most common explanation, which is she didn't take a deep breath and the timing of the X-ray wasn't great, and she might not have taken a deep breath because of pleuritic pain, or she has a rare complication of lupus, which is shrinking lung syndrome. This is a very good X-ray for one of the few pulmonary complications, intrapulmonary complications of lupus. So really, really excited, Ashutosh, for that next step. But this X-ray, if this patient turns out to have lupus and this X-ray is real, I'd really worry about that possibility. Really, really great pickup, Nalayan. All right, Ashutosh, tell us more.
Sure. So going on to the advanced lab sections, we did a serological test for HIV, hepatitis B, and hepatitis C. They were all negative. A bunch of locally prevalent tropical infections in Nepal, like scrub typhus, brucella, dengue, leptospira, they were all ordered, and plasmodium, and they came back negative. We also did a CT scan of thorax and abdomen, and I don't have the image with me right now, but the findings were bilateral pleural effusion and multiple enlarged retroperitoneal and mesenteric lymph nodes. The spleen size was normal. We did a pleural fluid analysis. The pH was 7.1. Glucose was 54 milligrams per deciliter. And the protein was low exudative range. I don't have the number with me. It was like a low exudative range. LDH was raised. And we did the Gram stain, AFB stain, and adenosine deaminase test, which is done in this part of the world for tuberculosis, which all from the pleural fluid, which was all negative. There was like no RBCs, no triglycerides there was, but nothing significant. We also ordered rheumatoid factor and anti-CCP, which was very high positive. Before that, I think I should have mentioned, we ordered anti-nuclear antibody test, ANA, and which came back positive, very high titers. Anti-DS DNA antibody was also positive, very high titers, and there was low complement C3 and C4. So just to summarize the antibody panel, like ANA was positive, the anti-DS DNA was positive as well. Complements were low, rheumatoid factor was positive, and anti-CCP was positive as well. I think that brings to the end of this section. Yeah, that's it.
Well, Prof. Rez, I'm so intrigued by Ashutosh's amazing presentation. And I think, as you said, now we have even more momentum for lupus with a positive ANA and a positive dsDNA. But the fact that the RF is positive isn't too swaying, because a large fraction of patients with lupus can have a positive RF. But the high titer and the positivity of CCP has me really, really intrigued. And especially since the patient had periarticular osteopenia, a finding consistent with RA. I'm starting to wonder whether you were right in the beginning by saying, wait, hold on, is there an overlap syndrome? So I don't have the expertise to say if this patient has both lupus or RA. I think she might have both. I'm curious where you're at.
I love what you did right there, Robbie. It's like you knew what the sensitivity of the RF is, which is not the greatest test for rheumatoid arthritis. But then you pause and you're like, wait a minute, but the CCP is quite specific. So it really affects the post-test probability of a specific diagnosis. I would like step back and ask myself, like, what was my pre-test probability for RA? And boy, it's not like the classic presentation of RA that I would think of. So I'm more open to the possibility of just this patient being so inflamed that a lot of these antibodies are going to be positive. And if I was alone on an island, I would prioritize the treatment of lupus. But I imagine the treatment of lupus is going to also treat the other underlying autoimmune process. So we'll see what Ashutosh teaches us. But I'm comfortable saying that this is, primarily lupus, and to treat it as such. And I think just to leave this last pearl is that we need a UA. We need a UA. Maybe it was already given, because that dictates how quickly and how aggressive you are with your immunosuppressive therapy and whether you should pursue with the renal biopsy.
Amazing, Ashutosh. Well, how are you thinking about this? Maybe you can take us to the conclusion of the case.
Oh yeah, sure. So like you just said, we were also very intrigued, like what to think of this case as, like, is it a primarily a lupus presenting with like lupus pleurisy and those things? But we interpreted the hand finding and the X-ray, because the X-ray had like evidence of osteopenia. I think we interpreted the hand finding as something that is, I don't remember it right off my head, but there are some deformities associated with rheumatoid arthritis. So we thought probably this could be, we were thinking about that, whether this is that or not. We had a great discussion about like, how is the pleural fluid analysis different? Although it can be like, it is very similar, but how is it different in lupus and rheumatoid arthritis? And one thing that one of my attending told me that in rheumatoid, you usually find like really, really low glucose level. And this patient had a glucose level of like 54 mg per deciliter. So that was one thing that we were thinking, like, yeah, this is why it is more likely to be a lupus pleurisy than like the rheumatoid pleurisy. But given the high titers, I don't know, this case was eventually diagnosed with something called as Rupus syndrome, RHUPUS. So, which is basically like an overlap of rheumatoid arthritis and SLE. This was the first time that I heard about it. And the first thing that came to my mind was, why is there a need of a different name? The thing that I learned out of this case was like, why can't we just say that it is both rheumatoid and SLE? Why is there a need for a different name? And then I learned that the presentation and the disease course is a little bit different in these patients compared to the lupus patient and rheumatoid arthritis patient. So a few points where like these patients are less likely to have renal crisis, like renal pathology, than compared to the lupus patient. And one very interesting thing that I've learned was while managing these patients, let's say if rheumatoid arthritis get worsens and we put the patient on methotrexate due to joint pain and everything, and if it fails at some point, then we'll have to switch to the monoclonal antibodies, the infliximab and those things, and which are all known to aggravate the lupus. So if it comes to that point that methotrexate can no longer be good enough for the patient, and we need to switch to these monoclonal antibodies, that can in fact worsen the lupus. So it is like balancing these two things in these patient population. And one last thing that I would like to mention was that the term itself, like the lupus term itself, I think what I found was that it was not recognized as a separate disease entity by the American College of Rheumatology, but it was something that is the term is used outside of US a lot. Most of the papers that I found were from China and India. So yeah, this case taught me a lot. Like, forced me to think about how do we even name a disease, and why there is a need for naming. Why can't we just call it like SLE and rheumatoid arthritis? Yeah, that's it from my side.
Ashutosh, I think this is an incredible case, and I think there's no doubt that the term lupus is accepted in the CP solvers community, at least in part because of how well you presented this case and the argument that you're making for it. And I'll just share. I can't wait to hear Professor's thoughts on the case. For me, this moment represents such a very, very unique thing that is happening in the world, which is the gathering of people all across the world to discuss medicine. It's very unique in this specific moment because I can't tell you the stereotype globally. If you say a young woman in Nepal presenting with fevers, subacute fevers, and dry cough, nobody would ever think autoimmune disease. And it's just a highlight of the sheer nature and form of the disparities and the biases that exist about medical education across the world. That not only is this person diagnosed with an autoimmune disease, which no answer to any board's question will ever be an autoimmune disease in a patient from Nepal. And it shows you that there are equally likely proportions of autoimmunity in many, many parts of the world. And here you are not only saying that this patient has an autoimmune disease, but has an incredibly intriguing autoimmune disease that we probably all would markedly overlook. If this patient got care in the United States, she would probably get subpar care because of how biased we would be about ruling out infections. And so I really commend you for being here, and I'm really excited to be part of this community that is really leveling the playing field and educating all of us about reality rather than the fiction that I think our short-sighted worldviews can sometimes have. So thank you. I am honored to be here and really excited to dive into the world of lupus after this. Prof. Rez?
I am just like smiling from internal to external. And like for me, why I'm smiling so much is because I'm so proud of Ashutosh. Like, if we have clinicians like him in this world, we are in good hands, because he kept asking, why does it matter? Why does it matter? And didn't stop until he arrived at this diagnosis, which I thought they were all joking with lupus. I was going to be an LOL, but it makes so much sense. And I also love how they analyzed each problem the patient had and was like, the pleural effusion, is it more consistent with RA or lupus? And then use subtle findings to say more consistent with RA. So Ashutosh, not only congrats on your presentation and to the CP Solvers team for creating such beautiful aliquots, but congratulations on the type of doctor that you are and the questions that you ask. I know I'll never forget this case. Thank you, my friend.
Thank you. It's my pleasure. I in fact enjoyed this time of the day a lot because I took until like 2 months ago, I was taking the boards, like the USMLE steps and those things, where you have like 90 seconds to diagnose a patient. And I'm just done with that, and I truly love this. I love how we spend like within an hour, we almost try to touch all of the internal medicine. And I would like to encourage everyone to present a case and keep learning from each other.
Thank you, Ashutosh. You were way, way too kind. And speaking of learning, we'll move from Nepal to the Dominican Republic to learn from our first time teaching points. Marino, take it away, please.
Wow, what an amazing case and what an amazing discussion we had about this amazing case. I mean, I was speechless. So basically, we started with this young woman that had dry cough and shortness of breath. And we talked about that patients usually present with more than one shift concern, and it's our job to decide which one we should tackle first. But in the case of this patient, we also had to tackle how to manage fever and inflammation. So when we think about fever, we know that we are in inflammatory state most of the times, and we have to classify the inflammation in 3 buckets. Is it acute, subacute, or chronic? About the cough, we agreed that cough is a non-specific symptom, and shortness of breath was the one we decided to tackle first in this patient because it is better to localize the diseases of the patient. In this case, mostly 95% of shortness of breath is attributed to the heart or the lungs. In this patient that had relapsing fevers, we should raise a really high concern for autoimmune diseases. By localizing the shortness of breath, we also had a little discussion about inflammatory cardiac conditions, and we talked a little bit about endocarditis, myocarditis, and pericarditis. But something that was really important in this is that we need to know the tempo of the disease and gives like a really big clue to knowing which situation we are in. For the inflammatory states, specifically in this patient, we decided to talk about the 4 Ws. So the first one was who. That means what are the risk factors for these patients, for this patient to present this kind of disease? What was the accurate description of the problem the patient presented? When is the time course acute, subacute, or chronic, and where the geographical localization? We talk about that many infections and many malignancies have different demographics and geographical distribution, so it is very important to keep that in mind. About later, when we were describing more things about this patient, we found that she had pleuritic chest pain. So we decided that pleuritic chest pain was a more specific symptom than shortness of breath. And we agreed on the 5 causes of pleuritic chest pain. We have pulmonary embolism, pleuritis, pneumonitis, pneumonia, and pericarditis. Also, this patient presented alopecia on the physical exam, and a framework that we discussed about alopecia is dividing it, is basically studying 2 parts of it. Is it scarring versus non-scarring, and is it diffuse or focal? In this patient, we had an alopecia with a combination of inflammatory condition, and it raised even more the concerns for an autoimmune disease. And we were discussing about, was it lupus or dermatomyositis? And each one has its own features, but we ended up knowing that it was lupus. In the case of this patient, an X-ray of the hands showed that she majorly had a non-deforming arthropathy, but also some kind of osteopenia that erased more the concern for systemic lupus erythematous. When we were talking about the autoimmune disease, we have the 3 Bs. So patients need to mostly have bad luck, bad genetics, and bad behavior. Tackling in the environmental and the geographical distribution of the patients. And also something really important is that rheumatologic diseases have most of the time overlapping features with each other, and this happened in this patient. On the CBC, this patient had pancytopenia, but when we were talking about the leukopenia, we had to know that autoimmune diseases, HIV, and tick-borne diseases are the main causes of leukopenia. So as the case advanced, we started to know that this patient mostly presented an autoimmune condition. So we were deciding on whether we should start immunosuppressive therapy or not. So before trying to start any immunosuppressive therapy, we need to rule out infections, in this case, mostly granulomatous infections like TB. So the chest X-ray was a really good finding in this patient. We talked about a complication of lupus called shrinking lung syndrome, that is a patient with lupus that presents with pleuritic chest pain, dyspnea, and pleural effusions. And basically, with the progression of the lupus, the patients get low filling volumes of the lungs. But we have to differentiate it from an incomplete filling of the lung due to the pleuritic chest pain. So it is important to make that adequate. And at the end, we got the antibody panel for this patient, and we found that she had a positive ANA, a positive anti-dsDNA, and also a positive CCP. So it raised, this is the time where we found that we were in a overlapping syndrome, in this case, rheumatoid arthritis plus lupus, and we agreed that the terminology we were going to use was rupus. And also, to finish this off, the urinalysis is key to evaluate how strong the immunosuppressive therapy will be, and also what can we expect when we decide to do the renal biopsy in a patient with lupus. That's everything I have for you, and thank you for your attention.
Absolutely amazing. Oh, go ahead, Prof. Rez, please, please, please.
Oh, no, I was just going to say, Marino, you should be very proud of yourself, my friend. Very clear, thorough, and engaging teaching points. Thank you. Mike to you, Robbie.
I just wanted to reiterate that I can't believe it was your first time, and excited for the many, many more to come. Thank you all for hanging out. Thank you, Ashutosh, for a really engaging mesmeric case. And thank you to Aisha and to Marino for making this possible. And to Prof. Rez from literally joining before your trip. That is dedication above and beyond. And really hope to see you guys at the next VMR. Bye.